So coming back a little bit to the practical aspects of the use of the ADC, compared to the CAR T-cell, we talked about the differences in the study design, the patient populations. They were more heavily pretreated. They probably were a little bit sicker, the CAR T-cell patients. But once these drugs are FDA approved, the antibody drug conjugates, what would be, in your view, the clinical benefits using such a drug over the cell therapies?
Yeah, I think they're exactly as you're saying. It's an entirely different treatment approach, right? So for the cellular therapy, you have to go to a specialized center, have a whole process of cell collection, then the cells have to be engineered, and then you have to come back, and sometimes there's bridging chemotherapy in between those two steps. But most importantly, as of now, you will have to be treated in a center that has been approved to give these therapies, that knows how to manage cytokine release syndrome, knows how to manage cellular therapy toxicities, potential neurotoxicity, whereas with the ADC, that's definitely an option for community-friendly treatment, meaning this drug could be available at a community practice, and in that situation, it's more being acquainted with the toxicities of that drug, which tend to be outpatient-related toxicities.
So let's talk a little bit about the toxicity. We talked about the fact that the first study showed 60% overall response rate, which is very, very good. When it comes to the toxicity at the presentations so far, as well as the paper that was recently published, including the expansion cohort, the two main toxicities that stand out when I read the literature is the thrombocytopenia and also the blurry vision. Can you give some more detail on that?
Yeah, so these are the top two toxicities, and there was even grade 3 thrombocytopenia with this drug. I guess as hematologists, and I'll just say my own bias, sometimes I don't worry so much about thrombocytopenia because I'm so used to managing it, but what's really striking about this particular drug is it does have ocular toxicity, and I believe 60 to 70% of the patients in this study experienced some kind of ocular toxicity. The good news is it was mainly grade 1 or grade 2. There were very few grade 3 events for this particular thing, but the less good news is it's ocular toxicity, and this does mean that there is some supportive care that has to be done, and it has to be known by the community physician or by whoever the treating physician is in order to manage this. So what they did was they used steroid drops very judiciously to prevent these types of toxicities. They did require treatment interruptions during the time that somebody may have had an event and had to pause, but then could go back on treatment. And actually there were a good number of patients that did have treatment interruptions. And then they're looking at other things in the future like cooling masks and different types of steroid drop regimens or schedules to ameliorate this. Ultimately, it might be nice to have a collaborator, like in a local practice, somebody that you know for referring for ophthalmology or even an optometrist to be able to measure this, but really listening to how the patients are feeling about it.
So I talked to some colleagues of mine at Sloan Kettering that treat other malignancies that are not hematology specialists. And I think there are other parts of the field in the oncology space where there are ocular toxicities have been around for a long time.
Right.
So other doctors in this field for a long time have had a collaboration with ophthalmologists. So it's not a new thing, right, from a little bit of a bigger picture perspective.
Exactly. And which is actually pertinent because not everybody is just a myeloma doctor, right? So if you've already had that experience as a general oncologist, then you will not be as worried to use this drug. You know who your collaborators are, you know what to expect.
And when it comes to these ocular toxicity, you emphasize that I think that's important, that they're grade 1 and grade 2, based on the current knowledge from the papers and the ongoing studies. Also that it's reversible. I think that's very important to emphasize.
Yes, it is reversible.
So it seems that the blurry vision, from my clinical experience and from our center, I think we have had patients in 1 or 2 weeks, but I think there are also some data saying that it could even continue to reverse up to a month or something like that.
Yeah, and it varies between patients.
Yeah, and I think we have had patients that had some blurry vision on some of the studies that were holding therapy, and then they resumed therapy again, and the symptoms were much less.
Right,
so
right.
I think there's more work to be done.
Yes.
But I think these are important nuances, that it's not high grade and it's reversible.
Right.
I think that's important.
And like all drugs that we used, I mean, imagine carfilzomib, daratumumab, all of these drugs that took a little bit of learning curve time, but now are very commonly used, not only in academic centers, but basically everywhere. So I think all of these things take experience, and us as a community, we have to make sure we put our experiences together, report on these, talk to each other, figure out how to manage these things, and ultimately, because if it works and it's giving a PFS of 12 months, it is up to us to try to implement these types of drugs.
I think that's very well said. It really works. So there's some work that needs to be done to kind of figure out exactly how to use it and how to manage clinically.